56. Page 56. Okay. We're starting this section, 5 and 6, these two sections, actually take us through a whole cycle of what medication administration is really all about. When you started, I think you thought, in fact I would have thought too, that medication administration is handing someone or helping someone take a medicine. But it's really a little bit more involved in that, and that's one of the reasons that we talk about it. We include a few policies in here, but you're going to get policies from your meetings that you have, specific policies that VOA has on how you document things and whatever. But we're getting, really in here, we're getting a lot about regulations and what medication administration is to the public and to the government regulators. We're going to talk about some types of information which must accompany an individual when visiting a physician. We're going to talk about ways to encourage individuals to represent themselves, questions which must be asked of the physician and or pharmacist, define the purpose of the prescription, how to verify if you've received the right medication from the pharmacy, information transcribed by the pharmacist to the medication label, what's important to be on that label, procedure to follow for out-of-residence medications, and difference between unidose and bulk container. So that's what we're going to do throughout this first lesson. This is the cycle. We observe our residents constantly, whether you plan to do that or not. You're watching, you're looking, you're observing. You're the first person on the scene on a daily basis, and you see any kinds of changes in physical or behavioral. So you see changes, and the most important thing that I think people should know is a change in behavior is the most important thing to document. Don't you notice that with your own family members? Someone quits eating. Why? They're not going to just quit eating. What's wrong? Babies don't talk to us, so we watch. If they're not eating, is it hurt because their throat hurts, they can't swallow? If they're older and they have a toothache and they don't want to touch it. So a change in behavior is very important. Then it's very important to communicate those. And we're going to report the changes. That change may cause us to visit the doctor. When we go to the doctor, there's certain things we need to take with us so that we can communicate correctly. And then from the doctor, we may receive something that we need to now go to the pharmacist, the prescription. From the pharmacist, we get the medication and we bring it in to the home, and we have to record this in a certain way and store it correctly. There's certain things that are required of us in the storage of our medication. And medications are drugs. I tend to use those interchangeably, but drugs is really the correct term. Medications are drugs. And the last thing we do of all of these things is we administer or assist in administration. And then from there we're right back again to observing, because we're observing for the therapeutic effect of that medication. And in order to observe the effect, we need to know what to expect. What is it we're supposed to be observing for? So this is our cycle of medication administration. Let's talk about observations. When we observe for physical or behavioral signs. And they separate these two things, and to me it's hard to separate them. And we see this here on page 58. Let's just look at what is said in your text here on behavior. The use of medications as a treatment procedure to influence behavior problems has increased dramatically. Prior to the discovery of tranquilizers, behavior problems were treated as sedatives and electric shock. So they're talking about mental health mostly when they talk about behavioral changes. But let's look at how we look at changes, and to me it can be either behavioral or physical. If we look at them objectively, we're using our senses, our 5 senses. We're seeing, we're hearing, we're touching, we're smelling, we could be tasting. Those are our five senses. And so in order to be objective and to be able to say, this is what I see, I hear, I touch, there's redness on the skin. I see redness. I touch heat. And I touch, and I can feel a change of the shape of that arm. It's a swelling. Those are objective symptoms. Subjective is what the client says to us. It hurts. Can we objectively tell about hurts, pain? I'm nauseated. Can we objectively know that someone's nauseated? No. We can see someone throw up, but we don't know they're nauseated. So things that are subjective, and then sometimes when we make a conclusion about things, that's our subjectivity into that. It's not what anyone said, but we can make conclusions, and we don't need to make conclusions. We just need to make objective statements. For instance, coming here this morning, there were 3 police cars on the corner of Gilbert and Kings Highway at a Circle K. Could have been a robbery. No, that was conclusion, wasn't it? All I saw was 3 police cars. Could have been getting donuts, coffee, saying good morning to each other. So all I saw was an objective symptom. So when we're talking about objectivity and when we record, we really need to record, especially when we're recording things to the physician. When we put on our form why they're coming, we put what we see or hear or touch, and we put what they say. My right side is hurting. And you can see them hold on to that right side and you believe it then. Okay, so that is the different types of changes that we can objectively or subjectively see or know about. And we report this. Well, we're going to now talk more about reporting and recording, because after we see or are told, we need to then communicate it. Communication, and you know, in any workplace, the lack of communication is the biggest problem we have. And you can believe that in your workplace too, can't you? If people don't tell you something or write it to you, and many times we have to do both things. Yes?
What you said, if they is a subjective, that means you saw it. If it's a subjective, they told you.
Right, right. And technically when you write subjective things, you say, he said, and you kind of put it in quotes. It's not critical to put it in quotes, but you need to say he said, or she said, or the client said. And that is very important to the physician. Many times people get frustrated with physicians because they said, all they wanted to know is what I was telling them. They should have told me what was wrong. No, a good 60 to 80% of your doctor's visit is what you tell them. And that pinpoints then what they look for. And the same thing with your client. Now we're going to talk some too about the client talking to the doctor. Do any of you take clients to the doctor? Okay, some of you do, and if you haven't, you will. And one of the things that we've done over the years, and we've done such a good job of it that mostly it goes real smoothly, is that we train the physician to talk to our client. Because many times, depending upon the level of needs of this client, the physician doesn't know that they can talk back. So they talk to you. And we have to direct them to talk to our client as well. Pediatricians are great because they've always talked to clients that don't necessarily talk back. You take in your child to the pediatrician, doesn't the pediatrician talk to the child? Yes, yes. They are great because they learned that. And one of the things physicians don't learn as well in school is communication. Isn't that interesting? So we're going to be talking about how to do all that. Okay, so recording physical and behavioral problems. What to report? we're going to skip over a little bit and talk about emergencies. Now, it's the next page is on 59, 60, 61, 62, 63, 64. They get real carried away with some things. And that's really all saying these kinds of things are objective. That's what they're saying. And if you want to peruse that, that's fine. It's nothing you have to memorize by any means. It's just things like vital signs are definitely objective, aren't they? We took that vital sign. It wasn't anything they told us. They didn't say I have fever and you said, oh, they have fever. No, you took their temperature. Okay. So now it's going to talk about some common emergency conditions, some things that, what to report, emergencies, when to report, all of that. So let's talk about that on page 65. So I really haven't skipped as much as it looks, have I? Okay, some common emergencies. Now this means when you call 911. And let me encourage you that if it is an emergency, you do call 911. Nobody's unhappy with you for calling 911 and having the ambulance come out and say, okay, it's all okay now. That is okay. That was a very responsible thing to do. Because if you were to put that client in your car and speed off to the hospital, I wonder about our guy who just died because he took himself to the hospital and he lost so much blood. If they had called 911 when that ambulance came, they would have started that IV right then. When you walk into the hospital, there's all kinds of chaos going on before they got him onto the gurney and started an IV. He might have survived if someone had called, or he had called 911. We make so many mistakes about feeling like we have to go right this minute. They are there and they start emergency procedures immediately. So 911 is the way to go. If you're having excessive bleeding, which you're unable to control, that is an emergency. I don't want to say that, but if it's a small excessive bleeding and it means you're going to have stitches, you probably could take that one in on yourself. I hate to say that after my big thing about 911. Huh? Okay. I know. Oh, terrible. If there's a broken bone, and a 911 is okay for a broken bone, definitely, because you don't want to mess up that break either by trying to support it in some fashion to get it in. You might make that worse. So if there is a broken bone that is noticeable, now we have a lot of broken bones that they go to the doctor the next day because we're not sure if it's really broken or not, but it's not dislocated looking. It's not outside of the skin, but one that is broken and needs to be secured. Okay, definitely choking, not breathing. Even someone who's been choking and not breathing and you've been doing the Heimlich and you get that taken care of, it's okay to have called 911 in the process of trying to stop the choking. Sometimes there's still something that needs to be done. Thankfully, they're now breathing, but sometimes there's still something. I had a resident not too long ago that was choking. They did call 911, they did get the choking cleared, but he actually had to be snoggled. They had to actually get more out. So it was important that he went into the emergency room. Of course, if there's no heartbeat, we don't just try to get that back and then take him in, do we? We call 911. These are things that are very, generally very necessary to consider that option of 911. They are emergencies. This may require calling the police if they're a threat to themselves or others. But it's okay to call 911. They know also if they need to bring the police in. And has anyone ever had that happen? Have the police come in because of a behavior? I've seen that happen. Yeah. Some of our clients are hefty enough that when they're aggressive, it is a serious thing. Okay, and loss of consciousness that's not related to a seizure. Or, in fact, it might even have that, a prolonged seizure. So a seizure that once it starts, and I don't know if we ever talked about how long a seizure is, but it generally only lasts about a minute. But if you really time it from the very onset to where they're really now totally out of it, it could be 5 minutes. But many times they come out of it, and I won't say many times, but sometimes they come out of it and go right back in again. And they hardly get out of it before they're back in again. That's considered a prolonged seizure, or one seizure after the other. During the seizure, they're really not getting enough oxygen to their brain. So that can be very harmful. So, excuse me, if it's prolonged, we need to call 911.
So if they lose consciousness because of a seizure, we don't call 911? Unless
They're really not conscious during a seizure.
No.
Some of them are. But a grand mal seizure, they're really not. They're not aware of what's going on. Well, actually, in any seizure, they're not really aware. So consciousness, I don't know how to tell you that about a seizure. Because they're really not conscious, but they might have their eyes open, yes.
You can call cluster seizures, prolonged seizures.
Clustered, and what do you mean by clustered?
When they back to back, you know,
Mhm. That's a prolonged seizure.
That's a prolonged.
Now, let me tell you something. On everything we do, you have to know your individual too. You may have an individual that is something they always do, and there's something you do because of it. Most of the time you can't give anyone medication during a seizure. So it wouldn't be giving a medication, but it might be something that stops it, and you know that. So if that's something you've been dealing with, now, if they have a lot of these things, well, in fact, we're going to talk about things that you have to go to the doctor for. And these, though, are things that are more life-threatening. And a clustered seizure, as you're talking about, is life-threatening. But if they've already been to the doctor because of it and you have a treatment plan, then that is different than when they first start doing that. Yes?
What if your client is prone to it, it's in their paperwork that they could, but never have had, and then they have one?
A seizure or if they have a seizure and they've had one in the past because they have a history of it, it's not an emergency. But
Okay, say they haven't had one, say like the last 6 years, no seizures, but all of a sudden they have one.
right,
Then we get through that, and then they have another one behind them.
okay, and you get through that. Okay.
Ongoing thing.
Yeah. Well, let me tell you what. I'll tell you what. You're never wrong to call 911. If you're concerned by their behavior, and you're the one who sees their behavior, if you're concerned by your behavior, you're never wrong to call 911. That one may not really, it may be when they come and they see that he's stable, they may say, do you want us to take him to the emergency room, or you just want to wait and take him to the doctor tomorrow?
Well, the way I see it, if they haven't had one in the last 6 or 7 years, and then all of a sudden have one, and it may be a change in the medicine or something.
Yes, and it means, which we're going to get to next, that they're non-emergencies, but they have to go to the doctor.
Okay.
So what we're trying to do here is decide what is the true emergency. But you know what, because I have 4 community homes that call me. And when they call me and they say, I'm wondering about going to quick care because he dropped the toilet lid on his foot. And it's looking pretty bad. And I say, if it looks pretty bad to you, you go to quick care. I seldom, I don't know if I ever say something different than what they think, because they're right there on the front line looking at something, and if they think they need to go to the doctor, I say, have at it. I'm not about to say, well, let's wait till tomorrow. Because tomorrow, it's gonna be twice as bad at that point. So, if you have something occur and you're very concerned about it, you call 911 if it's something that's an emergency, or you go to quick care if it's not as much of an emergency. We don't really have this line between emergency, non-emergency. It kind of flows, doesn't it? So there is a place where you know they've got to go to the doctor soon, which means I could take you to quick care. It's open. That could be something that's bleeding that you can't stop, but it's not uncontrollable as far as bleeding out. You're going to take them. You're not going to wait till tomorrow and keep pressure on it till the next day. Okay. When to report, how to report, and then non-emergency. Well, any of these things that you're doing, you report right away. And generally, even in my community homes, they call their supervisor before they call me. That supervisor is a lead person in their lives. And they say, that toilet lid fell on the foot. And she'll say, well, did you call Dottie? No, I'm going to call her next. I'm always next. And so, anyway, but you report it immediately. And you report things verbally and in documentation. We always have to document what we report. If it's an emergency, just like your CPR class, you may have to have one person calling 911 and you're calling the supervisor all at the same time. You may be providing the emergency first aid while someone else is calling 911. It's just like your CPR class. You need to be sure if you go to the emergency room that you have information for that facility. They need to know what medicines they're on. We often in our community homes, we take the whole medical record with us. Everything's in there, recent labs, their medications, how they've been taking them. My uncle has had cataract surgery, and that physician makes us bring the medication record in that has been documented. If it was, he's living in assisted living, but if he was living at home, the physician required us to be documenting on this medication record that he fixed. And so he wants to see that we're giving the medicine right. And that's just, that would be in your private home. And most of the time physicians don't ask you for that, but this doctor who's done the cataract surgery says he wants it. And when we take our clients into the emergency room, they want it. Okay, these are some non-emergency conditions then. A fever that's not reduced by aspirin or Tylenol or whatever your standing orders are. If it still has fever, and usually on your standing orders it says something about you can use it for so long and then you go to the doctor. Repeated episodes of angry, aggressive behavior that's not typical for that resident. They need to go to the doctor. What's going on that they're so angry and aggressive? Is something interacting with their medicine and not working? Diarrhea, which is not controlled by medication. That causes dehydration. We know that with children. Babies who have diarrhea, you have to get them in really quick. But all of us get dehydrated if that continues. An increase in seizure, and that's kind of your question about if they have a history of seizures but they haven't had one. That we could almost call an increase, even though we haven't seen it. And sometimes they've had seizure activity, the petit mal kind that we haven't noticed. However, I've noticed in my community homes, they know when those residents have the mild seizures too. They can see that change of behavior because they know them so well. Cold symptoms which last longer than a week, especially things that are getting worse. And then severe seizures for an individual who usually has a mild seizure. Now this is a change, and even though it's severe, if they come out of it, they don't have to go to the emergency room just because they've had a severe one, and they usually have mild ones, unless they get another one right after that and another one, and then it's that prolonged. But they do have to see the physician. The physician wants to know what's going on. Okay, any other comments? I love it when y'all have comments. So this is reporting and recording. It's still under that area. Okay, other health-related changes. Let's see, that must be something here. It's on 67. Okay, these are some other changes in behavior that may need to see a physician. Change in a sleep pattern. All of a sudden, they're not sleeping, and we all the time are taking people to the doctor, not necessarily the next day, and all of these things, or many of these things, I have them keep a log of what's going on. I have them keep a log if they get a high blood pressure. And they usually don't have a high blood pressure. I say, okay, every day at the same time, you take their blood pressure. Because a log to the physician is much more meaningful than one little report. They didn't sleep last night. Okay, how have they been sleeping over a week? So let's keep a diary, a log. Change in bowel habit, same kind of thing. Change in appetite. The very first time they say, I don't feel like eating, that is not in itself significant. It's a change that occurs over time too. And then physical ability, you begin seeing that they're weaker, they don't seem to have energy. Lack of energy is probably the better word.
I had a client
Okay.
that they put her on a different kind of medication, and all of that stuff that she did, and it was totally out of her range.
Unusual.
And it was a behavior pill that they gave her, and she stopped eating. She was up for 48 hours, you know, and without eating, without taking a bath, without nothing, and she was just, you know, irrational. I couldn't make her do any of it, but I did document it.
And you know what? We only have 100 different pills of everything there is almost. Blood pressure medicine, if people don't do well on that blood pressure medicine, let the doctor know, because there's another 99 they could try. And a behavior medicine, they always like to start the new one on the market, because they've learned about it. It's supposed to be absolutely wonderful, but for your client, it may be horrible. And so you pay attention to that, let them know, and those are the things you're supposed to know, the expected outcome. And it's not expected, it's a whole lot of adverse effects. Okay, good point. When in doubt, oops, I guess I was just supposed to say something then. But when in doubt, you always err on the side of the best responsibility, and that is doing the best thing you can do for your resident. No one ever gets upset with our residents going to the doctor, calling 911, anything that you think is going to be much better for your resident. Okay, the medication cycle, if we're talking about assisting them to the physician, which is now on page 68. When they go to the doctor, if you've never taken them, you've probably never seen the form. Maybe you have, because you might have filed that form. But there is a form that goes with them to the doctor. Now, I started working in this field in 1978 with Evergreen House, which is now the Providence House. That's where Evergreen House was located. And Evergreen House was a home for, at the time we called mentally retarded residents, and it was like a dormitory. And they, on their own, got on the bus and went to LSU. And then they came back. We then became, more community oriented, and they were supposed to have more freedoms, but they actually had less. Because now they can't do anything they can't go on the bus necessarily. Now some of y'all do if they're supported independent living. But in order to have the doctors at LSU know why they were coming, we had to put it on a form. Because we might have been sending them because of an infected toenail, but they got there and they said, my ear's been hurting for 2 weeks. They do that to me. When I go to the home, they tell me something they haven't told anybody, and that manager says, "What? You didn't tell me your ear's been hurting." Well, they feel a need to tell me something. And when they go to the doctor, oftentimes, have you ever had that happen? They bring up something you didn't know. Okay, so in order, and that's fine, but the doctor needed to know why we wanted them to go too. They can bring up the ear if they want to. So, on the form, it says, coming for return appointment, coming for annual, coming for whatever. Their right ear, their left toenail. Okay. And again, it's no opinions, it's no diagnosis, it's that objective statement. Has been having pain, has been stating he has pain in the right side for 2 weeks. And you can see that he's been taking pain medication. Okay. That form also includes their medicines, because that physician needs to know what kind of medicines they're on. Now, if they're going to their primary physician, which at LSU, we didn't have that, but even their primary physician, you need to reiterate on that form what their medications are. They might have been to a psych visit and a new medicine was ordered and that primary physician didn't know about it. So we need to be sure it's on there. And so we now are giving them information. That's our communication tool, and that's what it was in 1978. Then, when the doctor saw them on the bottom of that page, that doctor at LSU wrote what they were going to do about that and what prescription and whatever. So when they got back to Evergreen House, we knew what went on. No one went with them, but we communicated by a documentation. It's the very same thing you're doing today. You're communicating with documentation, and if you're with them, you understand the documentation better because you heard the doctor say it. And so we can read it, possibly. We had to deal with reading. But anyway, so we know. Now, when you're there with them, you need to encourage that participation from the individual, and then you need to get the information back from the physician. If the information has something to do with the medication, you need to say, what am I to expect with this medicine? How long is it going to take?